Okay, so this is the continuation of the osteomyelitis chapter of station. So this will be osteomyelitis 2 video. Specific pathological name for pus around the screw or implanted plate. This is biofilm. And what is biofilm? A biofilm is an assemblage of surface-associated microbial cells that is inherent to the biomaterial surface prosthesis and encased in an extracellular polymeric substance. Matrix polysaccharide protein extracellular DNA. So what happens basically that the biofilm is this is the assembly of the surface microbes and extrapolymeric substance and the assembly of the these microorganisms. So this is extrapolymeric substance and the colony or the assembly of the microorganism and attached to the prosthesis. Let's suppose this is a nail, or external fixator. So this is biofilm. This is combinedly called biofilm. So it has the microorganisms, assembly, and the extra polymeric substance enclosing them, which is made of polysaccharide, extracellular DNA, proteins, and attached to the external fixator. Alternative biofilm is a centrophic community of microorganisms in which cells stick to each other and often also to the surface as well. What are its hazards? Biofilm are responsible for persistence of implant infections. So they antibiotics cannot reach the biofilm or penetrate the biofilm, and so the infection cannot be eradicated. So persistence of implant infections, source of bacterial dissemination to the other body sites, chronic inflammation as antimicrobial therapy are often inefficacious against bacteria growing in a biofilm. High cell density in biofilm facilitates high rates of mutations and horizontal gene transfer between microorganisms leading to antibiotic. Okay, so biofilm contains numerous bacteria, okay, attached to each other. So what happens that the problem occurs with these organisms that they cause mutation, they transfer their genes into one another, okay, so they causes high rate of mutation, and so they develop antibiotics resistance very early. Why should the fixing plate be removed? So the treatment is remove the fixing plate. So because the biofilm is usually attached to the surfaces or the external fixator, so it will go away with it. So it has become aseptic focus. Formation of biofilm less sensitive to antibiotics, and implant might be loose. Yes, implant can get loose when there is surrounding infection. The tissues is eaten. The tissue holding the implant is lost, so they liquefy, so this will be loose. Squamous cell carcinoma develop in the sinus wire due to chronic irritation. In chronic osteomyelitis, what is the sequence of events by which your draining sinus can develop squamous cell carcinoma? So chronic irritation, metaplasia, dysplasia, and squamous cell carcinoma. This is the general sequence of squamous cell carcinoma, SCC. Name of protein deposition in chronic osteomyelitis, it is myeloid AA. What will be your treatment option for acute osteomyelitis? So antibiotic therapy, blood cultures are taken, and high dose intravenous antibiotics activated against the Staphylococcus aureus, streptococci, and gram-negative rods such as E. coli are given. Okay, and cephalosporin, coamoxiclav, or combination of flucloxacillin and gentamicin may be used. Combination of flucloxacillin and gentamicin can also be used, and cephalosporin, coamoxiclav. Supportive treatment for pain and dehydration, splintage of the limb, elevate the limb, and surgical drainage. If there is no response to antibiotic for 2 days, then you can drain the osteomyelitis. Why risk of osteomyelitis is greater in rheumatoid arthritis patient then osteoarthritis, because the patients of rheumatoid arthritis, they are immunocompromised because they take immunosuppressant drugs, methotrexate and like this immunosuppressive drugs. So rheumatoid arthritis is an autoimmune disease, so there is immunosuppression also, plus they take the immunosuppressive therapy. What are the preoperative measures to prevent osteomyelitis after implant? So good preparation of the patient, diabetic control, preoperative weight loss for patient with obesity, smoking cessation, avoid long starvation hours, MRSA or methicillin sensitive aureus screening. First you have to screen them, and patient should be evaluated for the presence of active infection, particularly intraoral infections. So these are the pre-operative measures to prevent osteomyelitis. Pre-operative measures: prepare the patient well, lose weight if they are obese, control diabetes, smoking cessation, avoid long starvation hours, MRSA, methicillin sensitive Staph aureus or methicillin resistant Staph aureus screening. Patient should be evaluated for the presence of active infection, particularly in the intraoral. What are the intraoperative measures to prevent osteomyelitis? So intraoperative or antibiotics should be given 1 hour before the incision or 30 before the induction of anesthesia. Good preparation of the patient, avoid long starvation hours, aseptic technique, laminar airflow in the theater. So yes, what is laminar flow? So continuous flow of high filtered ultra clean air, high filtered ultra clean air, continuous flow of highly filtered ultra clean air moving with uniform velocity in a single direction along parallel fluid line. The filtration of air is through high efficiency particulate air filters, leading to supplied air uh, with less than 10 colony forming units per meter cube volume. The air is circulated under positive pressure into the operating theater from the surgical field to the periphery. So let's about this surgical table. There is a surgeon operating. So the air should move from the operative table away from the surgical field to periphery for continuous removal of surgically generated contaminations. It may be horizontal or vertical. After removal of implant, what will you do? Debridement and take swab for culture and sensitivity. You found the joint is swollen in the patient. One bedside test to do for the patient is joint fluid aspiration. What you look for the aspirated fluid of knee joint test to be done on the aspirate. So physical RE of the joint aspirate routine examination. Color, viscosity, turbidity, urgent gram stain, microscopy for cytology, polymer nuclear cells or lymphocyte crystals. Also go for crystals. Look for crystals as well, culture and sensitivity. You are given a pathological report showing increased protein, cocci, polymer nuclear cells. Increased protein, cocci, polymer nuclear cells. What would be the diagnosis? So septic arthritis related to implant. What do you think the cause is? Implant for the internal fixation. Common organism, Staphylococcus aureus. Differential diagnosis of swollen knee. So osteoarthritis or Aureus syndrome, septic arthritis, infections, gonorrhea, Lyme disease, TB, brucellosis, gout, pseudogout, calcium pyrophosphate deficiency disease, hemarthrosis, tumors, trauma, ligamentous injury, fractures, patellar dislocation, meniscus injury, etc. Polyarthritis, rheumatoid arthritis, Ritter syndrome, juvenile rheumatoid arthritis. So types of crystals in gouty arthritis. So gout and pseudogout. So we have monosodium urate in gout, calcium pyrophosphate in pseudogout, needle shaped, rhomboid shaped, negative birefringent, weakly positive birefringent. First metatarsophalangeal joint, which is called podagra. The first metatarsophalangeal joint. Okay, so we have the knee joint most commonly involved in pseudogout, red bud erosion and radiography, white lines of chondrocalcinosis. The treatment first line for both are NSAIDs. In these, there is in the gout is hyperuricemia, and in this we have the hypercalcemia usually. So these are the radiographs showing toffee donating. So this is your podagra or first metatarsophalangeal joint involving affected by the gout. And here we have the white lines of chondrocalcinosis in pseudogout. So these are the station about the